I know Jeff Bishop well enough that I don't need to read from this paragraph, but I will, in the interest of fairness. Jeffrey P. Bishop is a social and moral philosopher. His scholarly work is focused on the historical, political, and philosophical conditions that underpin contemporary medical and scientific practice and theories. His interests are diverse, with publications in medical journals, philosophical journals, theological journals, and medical humanities journals. Bishop has also written on diverse topics from transhumanism and enhancement technologies to clinical ethics consultation and medical humanities. His book, The Anticipatory Corpse, Medicine, Power, and the Care of the Dying, explores the way that anatomical ideas about the body's shape and inform the care of dying people from the ICU care to palliative care. He is currently working on a book on the philosophy of technology and the ways that our thinking about machines shapes how we think about the care of the human body. Jeff?
I've got to put this up because I've got a slightly different sort of presentation here, and I don't know how it's going to work. Okay. All right, so thanks to Melanie for using the word metaphysics, for being the non-philosopher who used the word metaphysics. I would have put metaphysics in my title if I had known I could get away with it. In fact, I changed my title a little bit to Attending to What Matters, and when I say what matters, I mean something kind of like metaphysics. So it's rather short-sighted to be critical of artificial intelligence, since every time someone says technology will never be able to do, you fill in the blank, technology goes and does just that. It fills in the blank. It succeeds. Yet, I'm so used to playing the fool that I'm going to ponder whether technology will be able to attend to what matters in medicine. As best I can tell, there are many things that I think technology will do better than the human. To me, those things are rather uninteresting. And at the risk of angering our future overlord computers, I will offer 3 areas in which I think machines will have difficulty. In part 1, I will describe a domain where I think AI will struggle. I'm calling it the difference between an it and a you. In part 2, I think AI will struggle in the gap between evidence and the N of 1. Can a computer make a judgment in the breach? In part 3, I will explore the gulf between our models and techniques for making diagnoses and the actual diseases themselves. So when a physician enters a room, she greets a patient face to face. However, she notices not merely the physical characteristics of the face, she engages with that which animates the face just beneath the surface properties of the face. One is, of course, looking at or reading the surface of the face, but at the same time, one is looking at something that seems to dance beneath the surface. Yet, what is animating the face is not merely beneath the face, but it is right there on the face. Put differently, when greeting a person, the physician, or indeed any human being engaging another human being, the person finds that which is beneath the surface of the face, gathering in excess on the face, so to speak. She sees on the surface of the patient's face not that he is an it, but rather she sees that he is a you. No matter how you size up the properties of the face, when one engages someone face to face, one is engaging in something deeper that is difficult to put words to. The physician makes eye contact, looking into the eyes, so to speak, but not looking at the eyes. But of course, I just said that. She's not looking at the eyes. She's just beyond the surface of the pupils to some sort of deeper recognition that someone is there. It is almost as if each person, the doctor and the patient, says, I am here, I see you. And he says back to her, and I see you as well. These two people in mutual recognition are engaged in a kind of deep reading of the surface of each other's face. Each is not looking at the surface of the face, for in reading the face, in the eyes of, in mutual recognition, one learns something that exceeds the property of the face. Indeed, the patient communicates something that is not yet verbally expressed, namely, that something is wrong. He communicates concern. The physician is not, however, merely quickly surmising or inferring that something is wrong from the properties of the face. Indeed, she does not look merely at the face. She is not drawing an inference. She sees that he is concerned, and immediately she is herself concerned. The transition is almost immediate between the perception of the face, the sharing of concern from patient to physician, and the understanding of the concern by the physician. Something concerns him, thus something concerns her, the physician. And a word has not yet been exchanged between them. Because of the unspoken concern communicated by the patient, the physician knows this visit is not just a routine checkup. Suddenly, out of the corner of her eye, she detects a property of the patient's eye, something a computer might see. She catches a glimpse of his eye, the surface of his eye. And by virtue of her training, she has learned the habits of attuned seeing. She is attuned to see more than the patient's concern. Her eye quickly moves from eye contact with the patient to look at his eye. There is a light yellow coloring of the sclera, the whites of the eyes. Just a hint of yellow hue sits on the surface of the sclera. Her own concern, which is also the patient's concern, drew her attention from engagement with him to look at him, at his eyes, to look at the properties of the eyes. She quickly, almost imperceptibly, moves from mutual recognition of eye contact to look at his eyes, his sclera, and then back quickly to eye contact, engaging him. And he may not even have noticed. Now the yellow concerns her further as she tries not to let her concern surface to her face. She does not want to further concern him, not yet anyway. Quickly, the physician's mind jumps to a conclusion. Something is really wrong. She wants to ask immediately, do you have any pain? Because a negative answer to this question will all but clinch the diagnosis. But she waits as she turns back to the niceties of engaging the patient. Yet as she does so, she glances at the surface of his face again, this time at the properties of the face. Is it yellow? Is it pale? Is it thin? Is it sweaty? What is his age? Does he have fat stores? With a quick movement of the eye, she will soon have answers to all of these questions. But new questions will emerge as she notices that, in fact, he is thinner, with pallor, with very little in the way of fat stores. All of this is done in a moment as she moves quickly from looking at the sclera and these newly found facts of the body back to his face and to his eyes, back to the niceties still being exchanged as she shakes the hand of the patient and then his wife. "What can I do for you today?" she asks. We are only a few seconds into the encounter, and yet already much work has been done. She already knows what questions she wants to ask. She has moved from the face to the properties of the face, back to the face, and then turned to the face, to the body, the eyes, and then to a different body. This time, the body of medical knowledge with all of its differential diagnoses. By quickly and almost imperceptibly looking at the it of his eyes, at the it of his face, the properties of his body, she has thought through several diagnoses, from the mere perception of the yellow sclera to the quick look to his age, the thinness, the paleness, the glint on his face, and the hollowed out portions of it. She has already moved past the first possible diagnosis of hepatitis and is with its myriad of possible causes from infectious to toxicity. She has arrived at biliary obstruction, thinking already about the possibilities of pancreatic adenocarcinoma. But she has not yet asked any other questions of the patient. She is waiting to hear how he articulates what concerns him. She says, "Tell me, what is going on?" "Well," he says, "I woke up 2 mornings ago and I was yellow." 2 days. Anything else that you have noticed?" she asks. "Not really," he says. "Well, he doesn't eat," the patient's wife butts in. "He's lost some weight, I think. He looks thinner than usual," she says. "How could I have lost any weight?" he says. "My appetite is as good as ever. I'm eating whatever I want." "That's not what I said," she corrects him. "I said, you have lost some weight. Your jeans don't fit. I didn't say you weren't eating." The doctor butts in to stop the bickering, and she asks the question that she has wanted to ask since she saw the patient's yellow sclera. "Well, are you having any pain?" "Nope," he says, assuredly, as if the answer itself meant that nothing was really wrong. The doctor's eyes shift up quickly to the sclera as she feels her own heart jump a little at his answer. A pang begins to rise up from her stomach into her chest, making its way to her face. But she is seasoned. She has learned to keep these things hidden from most patients. She places on a check on her own body, trying to prevent the concern from moving from deep inside her up to her face. Painless jaundice means one thing: tumor of the pancreas, possibly pancreatic adenocarcinoma, which is almost certainly fatal. So no pain when you eat. No pain that increases in intensity and lets off after eating a steak, let's say, or a hamburger or something fatty, or anything like that, she asks. "Nope, I'm fine," he says. "Now, what about this weight loss? Have you weighed yourself recently?" "No, but your scale said I weigh 182 pounds, and the last time I weighed myself, it was around 195. Yeah, I guess I must have lost some weight then." "Anything else?" she asks. "Any problems with headache, sore throat, eye problems, cough, palpitations, chest pain, abdominal pain, nausea, vomiting, diarrhea, change in your stools, fevers, chills, sweats?" He shakes his head. Uh-oh. Did that go off? Sorry. He shakes his head at each of those. "No, maybe a little nausea after I eat," he says. His wife, annoyed, says, "I thought you said you didn't have any pain after you ate, and that your appetite was strong." "I don't. It is," he responds. Interrupting him, his wife says, "But you said you were nauseated." "Nausea ain't pain," he retorts. The doctor interrupts the bickering again. "How long after you've eaten does the nausea start? Is it immediately after you have finished eating?" The doctor asks. "A few minutes into eating. Not right away, but before I have finished. In fact, it makes me stop sometimes. But it seems like it passes, and then I'm still hungry afterwards." "Well, you could have said something to me about it," his wife interrupts. "So you haven't been eating as much." The doctor interrupts the patient's wife and says, "Let him answer, as it will help me to better understand what's going on." Embarrassed and annoyed, his wife looks away. Now the doctor continues. "You were saying that you eat, get nausea, stop eating, but that you felt like you still have an appetite." "Well, it seems to me like I've been eating as much," he says, "but just some nausea." "But no pain?" the doctor asks. "Nope, none," he responds. "Any changes in your bowel habits, stool color, or blood in your stool, more frequent or less frequent bowel movements?" the doctor asks as the wife looks at him annoyed. "Nope, not that I have noticed," he says. "Not that you would notice," his wife says with a biting chuckle. I'm going to stop this description of this clinical encounter here and the work done by doctor, patient, and the patient's family to briefly do a bit of interpretive analysis. First, let me imagine what a machine will be able to do that the human doctor might also do, and it might even be better at doing than the doctor. The machine will be able to maybe size up the patient. The machine might be able to register the yellow of his sclera. It might even be able to do so at levels below what the human eye can detect itself. And it might be able to register the loss of fat stores or skin pallor pretty quickly. And it might be able to pick up on the quantitative measures that docs themselves use all the time, and possibly even a few qualitative things as well. But will it be able to have the kind of knowing that happens between two subjects, between an I and a you and an I, between people face to face? Will it be able to make eye contact in that knowing recognitions that happens between a doctor and a patient? Will the computer know that at any time the qualia of the concern that is recognized in the face-to-face encounter? It is not in a moment, it is known in a moment to the perceptive and attentive physician. Will the computer recognize the anxiety in the patient's wife? Will it understand that the anxiety expressed in the bickering may be related to fear that goes much deeper than the pigmentary changes on the sclera? And even if the computer recognizes that there is anxiety in the patient, will it ever understand what anxiety is? Will it know the patient's wife is annoyed at it? The doctor recognized the annoyance of the patient and of the patient's wife and turned her annoyance away from her husband and toward herself. Will the artificial machine doctor know to turn the wife's annoyance away from the patient and toward itself? While the machine may have knowledge, I wonder if it will ever have understanding, and I wonder if it can have wisdom of any kind. Is there a way to get the slides back up now? Okay. So, let's move to another domain, which philosophers Samuel Gorovitz and Alasdair MacIntyre noted more than 40 years ago, namely the element of necessary fallibility in medicine. Gorovitz and MacIntyre noted that there are three kinds of fallibility in medicine. The first is factual ignorance in scientific knowledge. It is the present limitations of human knowledge. There are things that the scientific community knows, and there are areas where it knows very little. This form of ignorance can be overcome by expansion of scientific knowledge. Another form of ignorance is the ignorance of a particular physician, the limits of a particular human intellect. With the limits of human intellect, the physician may be culpable for any fallibility if he does not or she does not know something that she should reasonably have been expected to know. It turns out that the machine might never be able to make the second kind of mistake, for it can download newly discovered scientific facts daily, even moment to moment, in a way that a human physician may not be able to do. Conceivably, the machine, Watson, let's say, might have every piece of knowable information just a search away. Thus, while a machine may not know the things of which the scientific community is ignorant, it will know every fact that the scientific community knows at that point in time, and it will possibly never be culpable for the second kind of medical error. However, Gorovitz and MacIntyre note that there is another form of ignorance to which the human is prone, and that I do not think that the machine itself can overcome. And I will argue that the human might overcome it, however, through judgment. So the problem is the gap between an evidence base and the N of one. All evidence-based knowledge is of the general. That is to say, it is based on generalizations in physiology, anatomy, pathophysiology, and other forms of hard science. While every hurricane acts according to the laws of the law-like generalizations of physics, no particular hurricane's path or its wind speed or its rainfall can be certain, because each has its own particular history. Every cardiovascular system will have a mean arterial pressure equivalent to the cardiac output multiplied by the overall resistance within the system. Yet, one cannot predict what any particular patient's heart rate will be if its resistance falls by a certain amount, or which patient will respond to pressors or to afterload reducers, or at what level the mean arterial pressure must stay for a particular patient to maintain adequate perfusion to oxygenate her kidneys or her brain. We can only guess at what levels the pressure should remain, in the general, because the particular history of the particular body in this particular bed escapes our knowledge. In other words, there is an infinite gap between what is known in the law-like statistical generalizations and the particular patient with his or her own particular physiology. It seems that Watson would only be able to play the statistical numbers. And while the physician might be able to play the numbers and might be just as wrong as the AI, I wonder if physician judgment fills the gap of what Gorovitz and McIntyre call necessary fallibility. By physician judgment, I mean something like the ability to play a hunch or to follow an intuition for which there is no hard evidence. Can a machine have a hunch? Can it have an intuition? And whatever you may think of hunches and intuition, those of us who have practiced medicine have come across those physicians that are more often than not right when standing in the breach between the law-like generalizations of statistical knowledge and the end of one that lies in the bed in front of them. This claim assumes that something like physician judgment is very different from algorithmic thinking, deployed by medical students and by AI machines. It is also open to empirical study as to whether physician judgment, if it is indeed something different from algorithmic thinking, adds to the physician's being correct in excess of machine judgment. Part 3, the gap between the model and the real. This painting is called Science and Charity. In it, we see science and charity together. On the patient's left side, we find charity, represented by the nursing sister who is offering care, caritas. She is offering grace. On the right side, on the patient's right, we see science. Science exercises passionless disinterest. Oddly enough, the doctor's eye does not fall on the patient. His gaze falls on the tool as he takes the patient's pulse. He is no longer concerned with the quality of the pulse, which physicians used to know about. I wonder how many of the medical students in the room, Kayla, are learning about the qualities of pulses. It probably still is taught, but you probably will never use it. So he is no longer concerned with the quality of the pulse, which physicians used to know a lot about, but now he is merely concerned with the patient's heart rate. The heart rate is, of course, an objective measure, one of many other quantia to which we can put numbers like blood pressure, temperature, respiratory rate, cardiac output, stroke volume, systemic vascular resistance, just to name a few. We might conclude that very little is lost when we move from the qualia to the quantia. In fact, the physician is better precisely because of this shift to quantities over qualities. And it would seem that when we shift to Watson, or whatever the AI of the future we may call it, we are not really losing anything, only gaining something. Except something is indeed lost, and it is depicted in this painting. While the painting shows that science and charity, or seemingly shows that science and charity are here together, it also shows us that they are separated in this painting. On the one side, the nursing sister looks the patient in the eye, face to face, offers her a cup of tea or soup while caring for her child. On the other side, we see that science has become less a subject of concern and merely an object over which the doctor lays the technological tool. Now, Science and Charity was painted by Pablo Picasso in 1896, and it won honorable mention in the 1897 Spanish National Arts Festival. This painting, La Mort de Casagemas, is a painting completed in 1901, a few months after Pablo Picasso's best friend, Carlos Casagemas, killed himself. The suicide of Casagemas sent Picasso into a depression, and whereas Science and Charity is considered to be Picasso's last painting before his blue period, this painting is recognized as the first painting of Picasso's blue period. You will recognize the more familiar blue period paintings in this one that is titled Woman with Folded Arms. This painting is a representation that captures something of the way the world might look when one is depressed, and it is itself a representation of depression. In fact, here are two more representations of depression. On the left, Picasso's The Old Guitarist. On the right, Beck's Depression Inventory. Both are representations of depression. The one on the right captures the mood, the feeling, the shading, the texture, the weightiness of depression. The other captures something of depression, but it is hardly recognizable as depression. It is a tool, a technique, a technology. It might permit us to pick out depression, but it is a passionless disinterestedness. It could hardly be recognized to the patient as something of her own life. But does this representation capture anything of the reality of depression? Surely it does, but it is an abstract painting of depression. Only those with the correct way of seeing could possibly see it. Thus, it seems to me that the machine can only have the model, the image on the right, on the left, a different kind of representation, which seems to be a thinned out and pale and pathetic painting of a much richer and more vivid and terrifying reality. The machine might be programmed with its techniques, these thinner models, these simple drawings of medical models that seem to do so much work for us, but do not capture the richness of the reality and the patient's experience of that reality, or the reality of a failing body. The wise advice given to humankind by the oracle at Delphi was this: know thyself. Socrates, in reflecting upon his impending death, puzzled over the fact that the oracle had proclaimed him, Socrates, as the wisest man on earth. Socrates concluded that his wisdom could only exist in the fact that the only thing he really knew was that he did not know. He did not know himself. The wisdom of the tradition of the Jewish literature says that the fear of the Lord is the beginning of all wisdom. The fear of the Lord is the recognition that I am not the Lord God, that I do not possess full knowledge, and that is wisdom. Wisdom, then, is something of a recognition of the limits of our knowledge, the gaps and the gulfs in our knowledge. Wisdom, then, begins when I acknowledge that I do not know. In fact, we only know things in terms of other things that we think we know. I would have done much better in college if I had known that psychology was really biology, biology was really chemistry, chemistry was really physics, physics was really mathematics, mathematics was really logic, logic was really philosophy, and philosophy was really psychology. We always know things in terms of something else, analogically. While our tendency seems to be to imagine that computers or artificial intelligences will be able to do everything that the human being does, I wonder if the metaphor does not already go in the other direction. What I mean is this: perhaps our disillusionment with the coldness of healthcare originates in the fact that we already imagine that what the doctor does is an act, a machine-like act, an algorithmic. He acts in an algorithmic manner. Perhaps we are already thinking in terms of this tool. I wonder if our predicament is not mediated by the fact that we already think that what we do and what we ought to do is to think like a machine. Maybe we are not wise precisely because we think we know that our knowing is the same as a machine's knowing. Thought this way, the technology not only distracts us from what matters, as in this image, but we imagine ourselves as already engaged in a machine-like, algorithmic, technological exercise. But the good physician, the wise physician, is supposed to stand in the breach between the body as an it and the patient as a you, between the law-like generalizations and the particular in of one, between the model and the reality, to humanely and to wisely stand in the breach with the patient. I'll stop.
Questions? All right, I'll start. So I was thinking about the dogs from Melanie's presentation, and I mean, it's just sort of an interesting, where's Melanie? Okay. That, you know, one way of categorizing the people walking dogs would be like, okay, this is a dog on a skateboard, like there are all these sort of iterations, but that another way would be based on the kind of quality of different relationships that people have to dogs and to dog walking itself. You know, you could think about a professional dog walker, about somebody with a service dog. You think about somebody that their dog is their only friend in the world, and someone who hates their dog and is thinking about euthanizing it for some spurious reason, okay? You know, and that happens, by the way. So, you know, I guess would your goal to be to have machines that could better grasp those kind of qualitative distinctions? I mean, should that be the goal, or is your goal rather that we should know what the place of the machine is, and the machine could be very good at determining the difference between a dog on a skateboard and a dog on a snowboard, for example, but not at grasping these other things, and that should sort of be out of the frame?
Well, what it should be, I don't know. I guess in part I'm wondering if it can ever be that, precisely because there's a way that our knowledge analogically, I'm going to keep coming back to that, Melanie used that today, comes back to a series of relationships, a series of relationships of words, which means that it is always going to be culturally based. The humility that's necessary in that is to realize that my culture is not the culture of every other culture, and therefore I could always be wrong in the way that I make judgments. So will a machine ever get to that point? I don't know. Should machines get to that point? Well, yeah, because I think humans do this sort of thing better. And I actually do think it's back to the point of intuitive metaphysics, I think is what Melanie said, we do name what things are. We have a sense of what they are, and that's always conceptual, that's always put into words, and that's always cultural. And so it's culture all the way up and all the way out. And so it has all of the biases. So what we need then, I would argue, is a kind of wisdom. The machines would have to know its own limitations. And can the machine know that it made the wrong judgment in that moment? I certainly have made the wrong judgments in practicing medicine. And then pretty quickly after that, I recognized that I made some sort of error in that. And I think that's part of, maybe it's just fuzzy logic, and maybe we can have machines that can do fuzzy logic. But it seems to me that humans are qualitatively different. And the other thing that I think happens is that we assume that really all that things are the information that makes them up, as if the material that makes them up, this is why I say what matters, as if the material that makes it up has no bearing. As if whatever the human is doing could just be translated as information into a different material form, namely silicon, right? And I wonder if that's actually correct. Does matter matter? And it seems metaphysically that matter matters. And so I don't know that machines will ever quite be able to do what we think they'll do. I could be proven wrong, but then machines will still need wisdom, because the machines have to be able to step into that same breach that we always have to step in when we're practicing medicine.
So, going back to what you were saying about depression and how it's sort of a qualitative thing that you have to interact with your patient, what do you think a machine versus a physician? A machine could not experience depression, but not every physician will experience depression as it's clinically defined. What's your opinion on that as a machine?
Humans have this remarkable ability to imagine things, and the wisdom, we fail in wisdom when we think that our imagining them is the same as experiencing it. Okay, so wisdom is always there, needed in that point. But we have this capacity to imagine, to reach out beyond the limits of our own experience and to imagine what that is. That's what science is, in fact. Science is just an imaginative process to reach out beyond what it experiences and to try to imagine what is possible out there in the world. And then you test it and you say whether it's true or not true, right? Science can be wise in that way as well. So what I would say is that we have this remarkable capacity in the norm, okay, this capacity to somewhat feel only differently, analogically, differently. Analogy always has the sameness and the difference, right? And so imaginatively, I can analogically sort of take on what it might feel like to have depression. But that still has identity and difference. I have to know that there's a difference there and never do that. So never reduce the patient's experience to what I am imagining that they experience. But I still have that ability. We might call that empathy too.
Thank you. You just asked, does matter matter? And I was thinking about when you're training a system or training a dog, training a person, when we as humans err, for the most part, for those who don't have a pathology, we feel bad. We have a physiological punishment to our system that goes some way to training us to then learn how to act correctly the next time. We have external triggers or external factors that influence how we should act. Could it be to your question that are we limited? Will AI be limited in its ability to develop intelligence or wisdom simply because of the fact that it doesn't really care if it makes a mistake, as it is not a feeling being?
Well, that's I guess, in part what I'm getting at, and this is why I say attending to what matters, right? I mean, we know what matters, and so we feel something bad when we see that what matters doesn't rise up to the level that we think it ought to rise up, right? Now, will machines ever feel? I don't know. That's way beyond what I can speculate. But if they do feel, if they someday do get to that point, well, then maybe they will learn kind of like humans then. So I just don't know if that's possible. And there's another dimension to that too. I mean, so we have the negative feeling, but then we have to be wise enough not to let the negative feeling so overwhelm us that we don't step back into that same sort of situation, right? And so there's a dimension to this that we still need to rise above the negative feeling even in order to be able to actually reach back out into the world and to once again try something new. And it doesn't mean that that there's some blueprint perfect human being that feels a certain way or has a certain level of negative feeling when something bad happens, as opposed to, I mean, there's no blueprint for that. It's just we have to learn in the breach of all of that, right?
Might the opportunity with AI allow the science to hold hands again with charity?
That's a good question. I mean, I think what I like about the painting is that the physician is, the classic understanding of a physician of that era and bleeding into our era is that we are passionless disinterestedness, right? That somehow that gives us the truth about a reality. And yet, if you look at that, to me, he's also distracted by the technology. So it's already divided there, and can the technology itself ever bring them back together? I hope so. But it might actually be something that we have to do as the humans, and not on the side. We got to time out here. Not on the side of the machine. It might be on our end. So.
Are we out of time, Jason? Is that okay? I mean, just so in terms of that painting, it's just sort of interesting to me to think about, well, maybe if the machine could take care of some of the technical aspects, that could allow the physician, assuming we haven't replaced the physician at that point, parentheses, big assumption, to sort of take on, and maybe that role could change in some ways.
Maybe we all become nurses, which is what we probably should be. So.
Okay.